Hello, everyone. It's just a minute or so before the top of the hour, so we're going to give people a few more minutes to join, and we'll start promptly in about a minute or so.
Public service announcement. I think I found the grossest drink ever.
And that is what?
This stuff.
What is it? Ugh.
Coconut flavored sparkling water. COVID exploration.
Well, good afternoon, everybody, and welcome to this week's AAA's COVID-19 clinical update. My name is Scott Moore. I'm the AAA's HR and operations consultant, and I'm joined today by Dr. Ed Racht, the Chief Medical Officer for Global Medical Response, and Randy Strozyk, Senior Vice President of Global Medical Response as well. Just few housekeeping issues right off the top. All participants are joined in listen-only mode. So if you would like to ask a question, please just use the Q&A feature in the control function in the Zoom platform. Certainly, if you are going to do any chat using the chat feature, that's for informal communications. As we do every week, Amanda usually scribes and keeps some notes for us as we roll through the update, and they are made available for attendees after the event. So with that, I'm going to want to start, of course, happy EMS week to everyone. As you know, certainly it was a different kind of EMS week this week because of the COVID pandemic. I know usually there's a whole ton of events like cookouts and all kinds of social events at different EMS agencies around the country. Of course, that really isn't possible this year, not only because everybody is out straight, working and also trying to stay somewhat socially distanced. I know up here in the Massachusetts area, we had a very cool sort of convoy of over 50 ambulances that rolled from the western part of the state all the way and ended up, as you can see in that top left-hand screen, in Fenway Park. And so they ringed the entire park in ambulances, both from not only private for and not-for-profit organizations, but also a fair representation of fire-based EMS. They had a whole bunch of speakers there, including shout-outs from the governor in Massachusetts and a lot of political figures, and Devin McCourty from the Patriots, the Kraft family, as well as the heads of both the Red Sox and the Boston Celtics. So just wanted to, wish everyone a happy EMS week. And hopefully, I think as it relates to the entire purpose of EMS week initially, rather than cookouts and little giveaways, really was to raise awareness about EMS. And for sure this week, I don't think, seeing the last couple of weeks of Time magazine covers, we could possibly be any more in the front line. So, and in the spotlight. So I really want to thank the frontline providers for representing our profession as well as you do. So with that, I'm going to pass the baton over to Dr. Racht to take us through just this week's update.
Great. Thank you, Scott. Hey, everyone. I'll add my happy EMS week greetings to everyone. This is clearly the oddest EMS week I think any of us have ever had, but I would also argue it may be one of the proudest. When you look at everything we're doing and how we're doing it, it's hard. EMS is hard right now for a lot of different reasons, and our little successes along the way, little successes in battling the bug, successes in kind of retooling what our responses look like, of supporting the folks that we work with, create a lot of that pride. So happy EMS week. I hope this weekend is relaxing, restful, socially distanced, physically distanced and socially close, and you have some downtime. So what I wanted to do today, because all of us have struggled with trying to grab a hold of what the testing concepts are for our COVID friend, and figure out how those testing concepts may apply to us in the healthcare arena and specifically in the EMS arena. If I could get by the way, this was, it's a very valuable test. The applicator for this particular test is extraordinarily long. So the drive-through does require you to actually get out of the car, put your hands on the back of the car. Can I get the next slide? Thank goodness Scott's laughing. Otherwise, I'd be going to HR.
Yeah, that really,
I'd be going to a class if HR was just, Scott, if you were just staring at me, it'd be like, you're going to a class.
No, you're still going to a class. It's just, I don't work with, I'm not your HR director, so I'm just laughing because I don't work with you.
I think I've got credits. Can we move to the next slide, please? So this material that I'm going to talk about is valid until May the 22nd, 2020, and that's important. I put that up there half tongue in cheek, but actually this is more realistic in terms of any evolution of approaches to medicine than I've ever experienced in my career. So this testing journey, and I'm going to try and highlight specifically why it's been a bit of a challenge, changes rapidly. And I mean changes, overnight changes. So next slide, please, Scott. If the material I'm going to present is very, very well defined in the CIDRAP viewpoint that was just published 2 days ago. So Mike Osterholm, who is a brilliant researcher, epidemiologist, he and his colleagues recently published this. It's a comprehensive document. It is really targeting communities and public health, and certainly applies to activities that we're doing. So I would encourage you to look through and read the whole document. Next slide. So there are, and I'm going to kind of summarize some of this. For some of you on the call, this may be old hat. But I think it's important to summarize kind of where we are in the testing arena and what that means. There are 3 categories of tests that are currently available on the market: molecular tests, antigen tests, and serology tests. The molecular tests are what we started with. So that's the up the nose with the testing swab. That's the test that identifies the presence of the virus. It really looks at the genetic sequence of the COVID-19 virus. You get it through the nose, oropharynx, you can get it through saliva, but you get that stuff here. It's a point of care test through several other companies as well, and I'm going to talk about that as well. But the valuable tests currently still remain laboratory-based testing technology. Relatively recently, there have been some antigen tests that have been introduced to the market. The antigen test detects, again, the presence of the virus, may detect fragments, viral debris, viral crap that's hanging around when the intact virus is no longer present, uses proteins on the surface of the virus. So this particular test struggles because it's not as specific as some of the other tests, and I'll talk about that in a minute. And then finally, serology tests. I think everyone on this call has been approached by someone, either in public health or a hospital or a labor representative or someone to say, we need to be tested for antibodies to make sure we're safe. They measure antibodies to the virus, and it determines evidence of current or previous infection. Next slide. So those 3 tests are, Mother Nature gave us some gifts associated with these tests. One is, we are learning more about infectivity of the virus, and the people that are really smart about this identify that it may take up to a week to develop antibodies after infection. So some would say, wow, that takes so long. Others would say, damn, that's very fast. Because if you look at our historic 2 to 14 day incubation period, this says that the antibodies start to show up in the bloodstream, IgG, IgM, and I'm not going to go into the details of IgM, IgG, but if antibodies show up at a week, you may well be into the beginning of the illness. Misinterpretation of that antibody presence could suggest, well, hey, you've developed antibodies, your infection is resolving, and that's not the case. Antibody tests are not valuable in determining the presence of the infection. So in a few, over the past several weeks, a few EMS systems have explored implementation of serum antibody testing to identify those folks that are, quote, safe to go back to work. The new term is the immunity passport. As we'll walk through in here, that is not the case. That is another one of Mother Nature's gifts to us. The sensitivity and specificity vary widely on testing. And this is a damn it clause, because what this particular challenge means for us is I can have testing. The White House can have testing. Your partner on the ambulance can have testing. And because of differences in sensitivity, I may have a negative test, but I have illness. I may have a positive test and it's related to a non-COVID scenario. So what that means is testing is a piece of the puzzle. It's not the entire end all at this point. I think one of the things this paper really identified is that, we've got to be careful that a negative PCR, a negative viral test swab, does not mean that we or our patients are not infected with the illness. It's a series of approaches. False negative, false positive rates worsen the spread, because if we do make decisions based on that alone and feel secure in that, we may put someone who is ill spreading virus back into the workplace, or we may say that somebody is safe based on the presence of antibody. The antigen tests have really low sensitivity, as I talked about. So for now, I think most folks, as of today, this hour, most folks are saying, yeah, the antigen tests themselves have a long way to go. And then we talked about a negative test post-exposure absolutely, positively does not rule out infection. Next slide. This little puppy came out a few days ago, and this is what kind of rocked the whole point of care testing world. This is an FDA update on the Avid ID Now point of care testing. My guess is many of you have had your providers, or some of you may even be using this technology in a contract to test individuals. It is point of care. It can be, the results can be can be obtained relatively quickly. But the Avid ID Now point of care testing has been identified to have anywhere from an 8 to 10 up as high as a 50% false negative rate, meaning you can swab me, I'm negative, and it's a flip of the coin. Half the time it's right, half the time it's not. What this particular FDA alert identified is that negative tests from these technologies need to be confirmed with PCR testing. In practicality, what that means is if I test you with this rapid test and you're negative, I still need to send another test to confirm that indeed you are. That may take 2 to 3 days in a good environment. And if that's the case, I can test you, see you're negative, say you need to self-isolate, and I need to wait on a secondary test. So many are asking the question about how that fits into the testing sequence. Next slide.
Real quickly, Ed, why is that test 50% error rate? Is it just sensitivity?
So good question. There's a lot of potential reasons. One of the biggest is sample acquisition. And I think we've talked about it on this call before. All of these tests require a fair amount of diligence in doing the test right. And if the sample's not obtained correctly, if the test isn't run correctly, the potential for false negative exists. The worrisome side, Randy, to your question, actually twofold. One is that you would have the wherewithal to ask a question like that. I mean, I've never assumed you were able to tie shoes and ask questions like that. But two is, if indeed it's the test technology that's looking at that RNA that's showing that's not able to identify the RNA, that means the test itself, not just acquisition of the sample, may be a problem. And in the long haul, that means the test approach wouldn't be valuable to us.
Okay.
So to to try and wrap around why this is happening. It's like, come on, hello, you know, I can go to Walgreens, I can get a rapid strep test, I can go to my doctor, I can get a glucose in the back of ambulances. Come on, all these other tests, we don't hear about that. So what the FDA did with rapid testing, everyone knows, is they use the EUA, so the Emergency Use Authorization. The FDA said, look, this thing's nasty, it's bad. You go out there, you build a test. We're going to assume the test has its controls. You can launch it. As a matter of fact, you might even be able to launch it 15 days before we even issue an EUA. And people can use that because we've got to, literally, we have to figure out what this animal is. The serology testing, the blood test, was given even less oversight until it was realized that there were significant issues with false positives and false negatives. And the FDA, after the tests were released, now requires much more comprehensive oversight for the serology testing. So every single one of these tests that are out there will hopefully be okay, but they haven't gone through the same rigid approval process because of what's going on as standard testing does. Meaning, for you and I, these things are going to continue to evolve. You know that every test manufacturer, and this is a good thing, is working their butts off to try and identify a reliable, consistent, easy to use, reproducible testing process. But that's not the case right now. Scott? So
You want next slide? Next slide.
Yes, sorry.
Scott's not controlling the slides.
Oh, sorry. Well, Scott, how are you
Amanda.
there, buddy? Amanda's doing it secretly in the background. Next push of the button. So here are the recommendations, and these are important. Again, it's in the document, but I'll go through them real quick because these are important for us. These are the recommendations of that consensus group that are important. So if someone's symptomatic and you need to know, it's like, you know what, you're short of breath, you have a fever, what the hell's wrong with you? For clinical care diagnosis, absolutely recommended. If you are symptomatic and you have been in contact with someone, absolutely, that's valuable. So if I have COVID and my partner in the ambulance is now symptomatic, absolutely use the test. For potentially exposed healthcare providers in that environment, all right, why did I lose my screen there? Did you guys lose my screen? Stand by. There we go, got it. For potential exposed healthcare providers, you or I, with mild symptoms, meaning I don't know if I came into contact with someone or not, but I gotta tell you, every single morning I have a Cinnabon bun, and this morning it didn't smell like cinnamon. So it is recommended now that those individuals go through testing. Next slide, Amanda, please. For patients or individuals or employees who are asymptomatic, meaning I am fine. Contact tracing, asymptomatic, that's a plus minus, meaning the consensus panel essentially said, if you're trying to figure out if there is an evolving number of cases, there are certain circumstances that you will use testing to try and identify contact. They were very clear that from an epidemiologic public health research standpoint, similar to what they've done in Boston homeless shelters, that they've done in prisons to identify prevalence of the illness, absolutely it's appropriate. Here's one that made sense to us in EMS, but they validated it. Congregate settings, long-term care facilities, prisons, confined areas. There is value in going in and testing asymptomatic patients. So state of Texas, for example, the governor has essentially asked fire departments in the state of Texas to test all long-term care facility residents and staff to identify presence of disease. But here's some stuff that came out that really helped clarify some things that are going on that probably don't need to go on. Universal testing in the hospital when you're admitted or for staff, not recommended. Workplace testing. So this is important for organizations like you on the phone, like all of us. When you come back to the business office or billing or those, do you routinely test asymptomatic patients? Not recommended. When school starts, does everyone have to essentially get tested? No, not recommended. Do you go out to the community and say, look, Austin, Texas, best place to be. We're going to test everybody? Not recommended. So there's some clarity from this document that really helps us with the asymptomatic individual. Next slide, Amanda. So the blood test. The blood test, remember, that's looking for antibodies, for donor identification. And in this era of COVID, really calling donor identification in the document really created some conflict. This is donor identification for convalescent plasma. Absolutely. So if someone was sick and you want to identify the potential for harvesting convalescent plasma, you have to do it. Clinical confirmation of infection, plus minus. There are circumstances where signs and symptoms are a little bit of a challenge. The patient was identified as having an infection. There are some challenges in managing the duration or prolonged illness. They could be recommending serology. Here we go. Here it is. There's only one of the recommendations in the entire document that said uncertain. And that was, do you test all healthcare providers? So it's unclear whether all healthcare providers should be tested for the presence of the antibody. Remember, even though you have the antibody doesn't mean you necessarily have immunity to the illness itself. Workplace immune status, nope, not indicated. And immunity passports, not indicated. Next slide. So what's the bottom line as of this hour? I think this helps us a fair amount, and it adds a little bit of sanity to this little monster. PCR, nasal testing, presence of the virus, the genetic material, still the most valuable for EMS decision-making for our employees across the board. Now, whether we use point of care or whether we use fixed-base laboratory, still being defined clearly per our discussion. If you want to be as close to the gold standard as you can, the point of care testing has a way to go. All the testing's continuing to evolve. Antibody testing, probably not for us in the long haul, at least at this point, but it may be valuable to see how a community is, quote, transitioning. And then one of the things that this particular document really spent a lot of time going through is it's time to get really smart people in there to define over the long haul what we do. Remember what we do for hepatitis B now with our own employers or our own employees. So that's certainly something to think about. So next slide, Amanda. And I was just going to wrap up.
So question.
Oh, sorry. Yes.
So Ed, you read all the time or you hear all the time on the news that until we get widespread testing, we're not going to be able to essentially deal with the virus or deal with the infection on a more effective basis. Yet, you know, the testing is hit and miss. It's got all kinds of nuances that I assume with time will be worked out, but maybe a quick explanation or a quick thought pattern why, you know, that the key to control, key to understanding, key to the epidemiology of this disease state is widespread testing, yet we really can't test.
Yep. So it was a mess up from the very beginning, widespread testing. They meant the SAT, ACT, and driver's license testing. So I'm kidding. This document addresses that exact question, Randy. And what it essentially says is testing is a part of the decision-making process, but it's not the end-all be-all. We can't say once we have testing in place that essentially, you know what, we are ready to open up, because the testing is not as clear as those on the news would want us to believe it is. The other thing that they spend a lot of time talking about is the number of tests. While it's important, that's not as important as the quality of those tests and what a community shows over time. So it helps to clarify that even though we're talking about that, that we still have a long way to go in that regard.
Great.
Well, thank you, Dr. Rock. Appreciate the update and the humor for sure. Just wanted to, one of the other things, and this really ties into some of what you were talking about, was that, you know, as most, I know my state here in Massachusetts really sort of starts its formal opening or the the beginning of reopening businesses and starting to open the state, really starting on Monday, although a lot of folks by the traffic outside my window now have already started that process. But one of the things that I wanted, and I know we talked briefly about this before, and I'm going to go back and update the document that I created for attendees and for AAA members regarding just sort of considerations for reopening offices. But many states have issued guidance, including the state of Massachusetts. They kindly put out, these are just a few of the documents that they put out relative to different industries and the requirements about their reopening their offices.
Hey, Scott, I'm sorry. Ed's got to run to another call.
Okay.
So we may pop up, but if we could just let him spend 2 or 3 minutes. He just got back from talking to people at Fidney and who are deployed in New York. Maybe just a quick chat, and then you can hop off to your other, whatever it is you're doing.
Well, that was Randy being all like
Nice.
insensitive and stuff, wasn't it? Sorry, Scott. No, I would
just asked me if he can go to the other call.
Right. Oh my God. You're right, Scott. He's an idiot. Just a quick note that I was going to make. For those of you who are in New York, you know about this already. A group of us went up the past few days. It's the most surreal experience I've probably ever had in my life. There is this interesting general flavor to try and get back to normal. And folks really struggle with what normal is. Folks are struggling with, there were a fair number of scuffles about masks, get away from me, or where's your mask, or I'm not wearing a silly little mask. We're in this for the long haul. Our folks that, and every one of us on this call are either out there on the front lines or are with folks. Being there for the first time in a high density illness area, wearing N95 for a prolonged period of time, that's not a fun thing. I'd forgotten how wonderfully fun that is. But also the concept of always being aware of everything you touch, everything you breathe, every place you go. That's going to be with us for a while. And it's part of the new norm, I think, of our EMS practice, clearly.
So, Dr. Racht, before you go, got a quick attendee question. Just thoughts on PCR testing for third test, day 9 or later. It's been recommended to us to just test employees on day 3 and day 6 after exposure. These have been asymptomatic. Of course, we've had people in the community test positive that were asymptomatic. The possibility of being tested past 6 days and then possibly infecting fellow employees.
Yeah, so I think, and that's a good question. I think there is a strategy buried in that. And that strategy is, and obviously whoever asked the question is spot on. That strategy is, I have a known exposure. And the document says if you have a known exposure, there is value in testing. If I am asymptomatic and I have a test early on in that transition, it may be negative. If I want to increase my sense that I have not contracted COVID from my known exposure, I would go further out with testing and confirm that I don't have presence of virus. So antibodies aren't going to help me, as we talked about, but moving further out would help you. Now, what I don't know and what I struggle with is the 6 to 9 day. Some have recommended the 12 to 14 day. I don't know that we know enough how far out you need to go. What we do know is if you have any of the symptoms, even mild, that's a point of testing. But in terms of how far out you would go to say definitively, you know what, I had a known exposure, known COVID, wasn't wearing my N95, sneezed, coughed in my face, how far out you need to go is not known. I don't know, personal opinion only, I don't know that a 6 and a 9 are as valuable as just going to the later. I think separated by that short a distance, you'd have to argue how many of those segments would you do. So if you want to be certain at this point, I would actually push it out closer to the 9 to 12, 14 range.
That's perfect. Thank you. So I know you got to drop off. Thanks so much. I hope you get to enjoy to the extent that you get to enjoy a long weekend at all. Thanks for coming on today. Appreciate it.
No, thank you, Scott. And likewise, everybody out there, happy Memorial Weekend. Enjoy it, have a little humor, have some physically distanced fun. So
thanks so much.
Appreciate.
Well, so just touching base back on the idea of reopening offices. I know most states, I think at this point, have begun some phased in approach to reopening their offices. I know in my state, starting on Monday, certain specific industries or employer types, and in particular, what really heightened my awareness to this was they identified any office type environment. And I know many of the attendees on here do, in fact, have billing and administrative offices that they maintain, some of whom have decided to rotate those folks out to a work from home arrangement and may, now that their states are opening, many people I know are just frankly dying to get out of their house to get back to some degree of what felt like a pre-COVID work environment. Some people are just looking to be around other people. And of course, that's part of the challenge. But in the state of Massachusetts, and I know in many other states, they've issued some guidance. And one of the things that was pretty universal in all the guidance that I saw was developing some type of COVID-19 control plan. So in other words, don't just open the doors and tell everybody to come back. Really take a look at your, not only, and we've talked about this before, take a look at your building spaces, not only just for your administrative folks, but also for any of the field personnel. This is not the kind of time that you'd want people bopping in and out of the stations when they're not working, not that they will be. But one of the things that I hadn't really given a lot of thought of, and probably should have foolishly, was the fact that you need to make sure that you're logging and maintaining enough information about the people who come to your physical building spaces, because from the purpose of contact tracing. So making sure that when someone comes to your space, not only is there adequate signage outside the building and within the building, possibly maybe making available to folks outside, a place where they could grab a mask, maybe some hand sanitizer outside the building or gloves, and then having them sign in and out with some contact information in the event that they actually are exposed, and you need to reach out to them, retroactively. One of the other things that you may do, though, is also put up a sign that essentially says, if you've come to visit this building and you subsequent to the visit in this building in the next 14 days develop symptoms, could you please contact us back? Here's the contact information. Maybe leave a card so that, or have cards made up that says, just please contact us so that we can at least begin to take precautions. Certainly limiting the access. And if you are an organization that has, that has control access in the building, certainly most of the time, a lot of those key card access will tell you who has been in or out of the building. But to the extent that you don't, trying to understand things like if there are elevators in your building, how many people can or cannot ride in that elevator. It amazes me how many people take an elevator one floor if they are capable of taking the stairs. But just making sure that you have some guidance, signage up in multiple locations, right? Understanding that you may need to make some building modifications or some office space modifications. Here in the Commonwealth, one of the things that they've said is, if you cannot have people at least 6 feet apart inside, let's say, for example, your typical 4-square cube setup with desks, that you need to have partitions that are at least as high as when the employee is standing. And everyone, of course, needs to be wearing masks. So that could require some modification to your existing office space. Identifying, so for example, break areas. If you happen to have a cafeteria at your location in Massachusetts, they've said you may only have prepackaged food, making sure that you have multiple locations for people to do hand washing and, of course, hand sanitizer and mask use. Communications, talking a little bit about, setting together, if you're going to develop this plan, making sure that you're communicating that plan to your entire staff. And as part of the plan suggestions here in Mass, they suggested that you reach out to your local public health to make sure that they understand, one, if they have any local guidance, because while there may be some state level guidance, your local government could have something that's more restrictive. So you want to be sure. The big part on the communications piece, and I think we've been pretty good at this, is making sure you set up some education for your staff, right? Not only because for our field personnel donning and doffing N95s and being really cautious about the infection control procedures. All of our office staff, and if you've ever sat outside a convenience store or grocery store and watched what people do with their gloves or their masks after they take them off, should be enough to tell you that likely the average person, and even possibly someone working in your office environment, has not had the appropriate training on how to, when and how to appropriately wear the mask, when and how to appropriately hand sanitize, or if you are going to use gloves, how to appropriately possibly, sanitize there or clean any of the office equipment that they're going to be touching. And to the extent possible, don't have people sharing office equipment. I know that can be challenging with things like copy machines or other things. So maybe identify one individual in the organization that's going to handle doing that. Making sure that you set out a very clear policy for reporting if people become symptomatic or if they need to be out sick, making sure that you have a champion at your organization who's really monitoring that. And telling folks, if you're sick, stay at home. Do us all a favor and stay at home. The last thing, of course, is having a good cleaning schedule, making sure that not only do you have a good cleaning schedule, but that you have a logging process for that cleaning schedule, because in the event that, in my state, if they will be doing some auditing or compliance checks. So you want to be able to show, it's not only, it's like when you walk in that public restroom and you've seen the last time someone was in there, there is and should be some systematic process for cleaning, not only just at the end of the day, but then periodically throughout the day. So I don't know, Randy, if you have anything to add to that before I move on to the next.
No, the only thing I was going to ask Scott, reopening. So a business opens up, and obviously I would assume everyone in our world would be sensitive, but they say, you've got to go back to the office. And the person says, I don't want to. Do you think this will fall under accommodation rules, ADA, name the law?
Actually, that's a really great point. So one of the things
good questions.
I know, it's great. We're writing it down, marking the calendar. So one of the things actually that the state of Massachusetts plan requires, or that you educate individuals within your staff about potential medical conditions that may make them more susceptible or more at risk to returning to the work environment. So that is part of the required education here in Massachusetts, but not a bad idea for you to be, one, if you can, there's really no reason not to stagger, or if people are working and working well at home, keep them at home, right? One of the things that we're hearing is that, if you can, they've gone from a stay at home to a safe at home sort of thought process. If you have potentially older individuals, and of course you need to be conscious about any disparate impact where you're, or disparate treatment process where you may be, preventing people, but offer the ability for older individuals who may be more at risk to be able to continue to work from home if they wish to. So I think everybody is relatively concerned about a second surge because of this reopening. Make sure, to the extent that you need to, it may be that if you have individuals in your organization who required reasonable accommodations because of a disability or some other issue, it may be that those, of course, accommodations would need to be reinstituted. It may very well be that they need to change in light of some of the modifications that you've made in your office. So if, for example, you've got to maybe disperse people a little more in the office so that they can abide by that social distancing. If you have someone who maybe you don't have an elevator in your building, they can't get to the second floor, to the extent possible, right? Make it so that you're accommodating their particular medical condition. Now, and frankly, as a rule of thumb, not all medical conditions reach the level of a protected disability. My suggestion always is, whenever and the law is pretty clear that if someone has a disability or you perceive them to have a disability, that you really need to affirmatively engage those people so that you can go through that interactive process. And of course, you should document that. Not all states have the requirements. State of New York requires a documented interactive process. I strongly suggest generally, no matter what state you're in, that you're documenting that process, because that's the best indication, of course, contemporaneously of what occurred. And you really just need to be doing, practicing good, legally compliant employment practices. So thank you for that, Randy. That was a great addition. So the other thing that happened this week was that OSHA released some revised guidance for the recording of coronavirus cases from a work-related perspective. And really, this guidance was directed at the folks who do their compliance safety inspections. So the idea behind this, and this is an amendment of an earlier guidance relative to when a case is recordable or not. And we've talked a lot about this in the early weeks about when something is a work-related illness. And generally speaking, in order for something, in order for a work-related injury or illness to be recordable, there has to be either an illness or an injury that the employee sought care for, beyond sort of standard first aid, that in fact they received that treatment and they missed time, and that there was a causal connection between the illness or injury and the work. So that still is the requirement. But one of the things that we weren't really sure is, that could be hard when you have an illness like COVID-19 that is really so spread out through the entire population. It can be very, very difficult to determine whether someone contracted that illness at work or whether someone contracted that illness at home. Now, with healthcare workers, to some degree, the first thing we think of is almost a presumptive, and there have been multiple bills that have gone through, and some states have had presumptive bills pass, where if a healthcare worker or a first responder contracts COVID, it is presumptively work-related. But on the federal level, we've not quite hit there yet. So one of the things that OSHA has required and put in this guidance was really just a little bit of information to try and help employers as they try and make that determination. And so what they've said or suggested are, you need to make this reasonable determination about work relatedness. And some of the things that the safety officers will look at as they're making that determination as to whether the employer made a reasonable determination would be just the reasonableness of the employer's investigation. So this isn't simply somebody sends you in a report of first injury or illness. What you need to do then is, to the extent that you can respect the patient or the employee patient's privacy, you are allowed or permitted to make some questions or to do some questioning of that employee so that you can find out to some degree whether, is there anybody at home who may be ill or who has been exposed? Are there, thinking about the work environment. So there's, to some degree, if the employee works in an environment where, like in EMS, where they're often around sick people, and you might, to some degree, do an investigation to see if any of the patients they've transported or encountered might have had COVID-19 or any of their coworkers. So in an office environment, this might be, if you've got 10 people working in an office, they are trying to socially distance, but other employees in the office have contracted the illness, then to some degree, that will weigh on whether you've performed that reasonable investigation. They also are going to look at what type of evidence was available to an employer at the time that they made that determination. So, what there may have been information at the time you made the determination that maybe it wasn't work-related, that wasn't available, that became available later. So that doesn't mean that if you find out subsequent to a determination that it wasn't work-related and then you learn new information, you can then go back and amend whether you can record that illness. Then the last piece that they look at was whether in fact there's evidence that suggests the employee contracted this illness at work. So for example, if in fact they had a known unprotected exposure of a COVID patient, then and that information exists, right? So sort of a more likely than not standard. In criminal law, we talk about beyond a reasonable doubt. That's not the standard we're thinking about here. What we're looking for here is it is more likely than not that this employee contracted this illness at work. And, they say that if you can in fact show that, you've made the determination that in fact it was not work related, and that you've gone through these steps, but then subsequently it turns out to be work related, that you will likely not be subject to any penalty because of that. So, but just if you're in your organization and you're talking with your safety folks, at least share the guidance with them, because you want to make sure that you're doing the right thing by the employee, the field provider. You also want to make sure that you're conducting a reasonable investigation, because one of the number one ways you may find out during this process that maybe they weren't practicing appropriate body substance isolation or, infection control procedures. That's something that, while you may be trying to find out how this person caught this, maybe there's a chink in the armor from an infection control bloodborne pathogen standpoint. So this is one of those things that what I would suggest, you document your investigation, you have some kind of log so that you know the steps that you've taken, and that you are incrementally logging each of those steps, and then at the end of that, making your determination. So that really is the latest guidance from OSHA. I feel confident that we're going to see more. The other thing that I've heard a fair amount about is retaliation concerns. So folks who have, as Randy brought up earlier, the employee who doesn't want to come back to work because they're afraid. And, this sort of piggybacks the employee who has voiced a concern while they're in the workplace. So you've reopened your office and the employee says, I feel like there are just too many people congregating in the break room, or we're ended up with, there's no restriction on the number of people riding up in the elevator. They can't socially distance. And so they voice that concern. You need to be really cautious as an employer and take that as constructive criticism, right? The constructive criticism is always welcome because it's with the intent of improving things, right? And if that individual were to file a complaint, any negative action they received from the employer because or due to the fact that they filed that complaint would be cause for a retaliation claim. So just if you find yourself, or you're not certain, or you go ahead and take a look at the web link that's listed here on the page, and you need assistance, reach out to the AAA, or you can even reach out to your local OSHA office, but certainly call us first. We're more than welcome, more than happy to give you assistance as it relates to this. So, Randy, anything to add on that issue?
No, I think you've done a great covering as always. Thank you, Scott.
All right. So, looking up, we haven't had, I know it's the Friday before a long Memorial Day weekend, and I think a lot of people have hit the wall with the amount of COVID stuff that they have had to endure. And I know I think this has taken a toll on a whole lot of folks. So I'm hoping the low attendance is one, because they're doing something cool for EMS Week for their folks on the street. Or number two, they've broken away early to try and get some appropriately social distanced Memorial Day weekend fun. But just wanted to pass it off for any final words before we close it down.
It's interesting. I wanted to do a couple call outs this week. Obviously, the EMS people across the country have all had to do different ways of handling our EMS week, social distancing, people just being worn out and tired. But a couple great things happened this week. Great, more positive PR to congressional offices and so forth about what we're doing. I see Wayne's on this call. Bell Ambulance has done phenomenal work across the country. We've seen things. We had a wedding, and while I am talking about a GMR event, it really represented everyone, but a couple who were engaged prior to deploying to New York after 40-some days. ABC, the Good Morning America, did a phenomenal thing, and they had the most amazing wedding you could ever imagine, COVID or not. There's been some great articles of people coming back home, after being different places. And I think we've just seen some great photos. These ones popped up here of deployed folks, and yes, there are AMR, but please just take this as being everyone who's done anything. So normally this time of the year, I'm at Indy. I'm standing on the track. I'm hanging out with my friends there, having a great time. All of you have your own things that you've done Memorial Weekend. It's different this year. We'll log it in the book, but thank you is too small. Come Tuesday, though, we're going to be back to working really, really hard on additional congressional support for us for COVID-19. And our new campaign is about CV4. We're going to be launching a lot of work with that, very specific with our ask on the Senate side. We've got to get relief for what we've done. It's not just PPE, it's about economic survival of what we do. And it's about taking care of our people, which is really, really important. So Scott, thank you so much. We'll be back next week. Next week, we'll probably bring Mr. Baldwin back, talk about the latest on vehicles and people and PPE. I think there's some changes. There's some crazy stuff with that. I don't know you'll have. Dr. Ed will be back. We'll pump this up. But to everyone on this call, thank you.
Yeah, and I'll just, as we close it out, and I love Rob Lawrence says, there must have been some onion chopping near me when I saw the wedding coverage, and I saw that as well. So, the one thing that I will say that I think, unlike and this, someone had mentioned to me, they thought that this COVID-19 response for EMS was much like sort of for this generation of EMS folks, like 9/11 had been for the last, the generation immediately before this. And one of the things that I'll say is that while there was a fair amount of recognition of what EMS did on 9/11, I have seen a dramatic increase in focus on what EMS providers in this country are doing in the response to the COVID-19 pandemic, and watching has been uplifting, no question. And watching how again and again EMS providers around this country step up to the plate with requesting little or no recognition whatsoever to do some of the toughest work that is ever done, and really truly risking their lives. I know one of my old partners was taken after being extubated after many days on a vent here in Massachusetts, and was taken to rehab this week. And there were, I want to say, 30 or 40 ambulances from different, whether private, for-profit, not-for-profit, and municipal ambulances in a caravan escorting him to his rehab. And I just, it's so nice to see that level of unity and that level of, appropriate publicity for what our folks do. And I just want to thank everyone. I want to thank you, Mr. Strozyk, for making, of course, Dr. Racht available for these, and for also sort of emceeing these with me every single week. So we will be back next week. And in the meantime, if, of course, you need us, the AAA is here. Certainly make sure you reach out to info@ambulance.org or through the website. But I wish you all a wonderful rest of your EMS week, as well as a wonderful long Memorial Day weekend. Thank you.